Welcome to this webinar on challenges in visceral trauma management, the good, the bad and the ugly, which is brought to you by the Visceral Trauma section of Estes, the European Society for Trauma Emergency Surgery. As usual, we want to make this as interactive as possible, so please ask any questions as we go along through the Q&A button. We will try to answer them during the webinar, either directly or with a written reply, or as part of the panel discussions. If there are a number of similar questions, we may answer them together. And if you ask a great question that we don't have time to answer during the webinar, we'll send you a reply by email afterwards. We have 4 interactive case presentations and a state-of-the-art presentation on the role of ultrasound in trauma. The case presentations will have interactive polls and all voting will be anonymous, so please don't be reluctant to take part. We want to know what you would do under the circumstances. We have an international panel who in order of presentation are Gaarder from Norway, Diego Mariani from Italy, Paal Naess from Norway, Shahin Mohseni from Sweden, and they'll be joined by Biloslavo from Italy, Falco Hietbrink from the Netherlands, and Henrique Alexandrino from Portugal as part of the panel discussions. We have a lot to get through, so I'm going to hand over now to my co-moderator, Gaarder, to start the first case.
Just need to know how to unmute. Good evening. So we called the case marathon for the good, the bad, and the ugly, and we'll leave it to the audience to judge which one is the good, the bad, and the ugly afterwards. We're going to take you through different kinds of trauma cases and with different mechanisms of injury, but also extremes of age, in order to focus on different challenges in our everyday trauma management. I'm going to start sharing the screen with the first relatively simple, straightforward case as an introduction to Diego, who's going to talk about ultrasound. Here we go. So we are partly going to be challenging the panel and for some questions, and partly challenging you as an audience. We have this 29-year-old male, and you get from the ambulance personnel, you get a warning to the hospital. They're coming in with an intoxicated young man, stabbed abdomen and left arm. He has abdominal pain. He is seen to be pale and with somewhat reduced consciousness. This is late Friday evening. This is not too far from the hospital where you work. They did load and go. They actually got to, on the way, they were able to put in 1 IV line. My first question would actually be, in this setting, to the panel, first of all. I think I can allow panel to unmute maybe to see, and then ask the panelists if how would you prepare for such a patient? I'm going to maybe challenge directly and say, just off the top of your head, Falco.
Yeah, so this would be a full employment of the trauma team, so major trauma call. And if he's still reduced consciousness as a first sign, we would probably also get the blood products already in the ER and up and running to level 1, and hold the OR for elective surgery, make it ready. We don't have the luxury of a OR in the ER as you do.
Okay, so this patient would go to your trauma room, and obviously with the trauma team. Would you order blood before this patient arrives from the blood bank?
Yes, I would.
Yeah? Yes,
I would, but I would go for a strategy of permissive hypotension. There is no history of brain injury. Mm-hmm. I would say this patient reduced consciousness is due to shock, he's pale, and I would get my priorities, ensure an airway and breathing, meaning either for a chest drain eventually in the ER, and then go straight for the operating room.
Okay, so, okay. So what you say is that this patient, I think what I read in what you say is that this is a stab abdomen, so this is a penetrating injury, and the patient is physiologically compromised, so he will need an operation or some kind of procedure in order to fix it, which is different from blunt trauma. And he needs to get resuscitated, start resuscitation, and he needs an operating room. He will need an operating room. Even before you see that even from this alert, to alarm operating room, someone would go directly to the operating room with this patient, bypassing the emergency department completely?
It depends on his vitals. I would do that if he's hypotensive when he arrives.
Okay. So that is maybe an option in some places. I think it's also about the emergency room is, most of the places is the setup where we're used to doing our primary survey, but we need to get very quickly through and into our operating room setting for this patient. Okay, so now the patient arrives, and this is what you find. His airway is clear. No neck collar was applied. Trachea is midline. He has equal air entry. Respiratory rate of 22, saturation is 100 with some oxygen. He's pale, sweaty. He is compromised. He is in shock, obviously, with low blood pressure, high pulse. He moves all four, but he now seems to have a GCS of 15. They find during their primary survey that he has one stab in his right fossa, okay, lower right flank. The omentum is sticking out. And then he has a non-bleeding laceration of his left upper arm. That's the only lacerations you find. What are your thoughts?
And that includes, Tina, may I ask a question? That includes having rolled over the patient, because the patient in shock with a stab wound, it's very likely the patient has a posterior dorsum or lumbar or even a high thoracic injury, who is not clearly viewed if we only treat this patient as if he's a blunt trauma without moving him. So I suspect you consider this patient was rolled over in the emergency department at this stage.
So when would you, I completely, that's an extremely important point. So one of the most important things you do during the few minutes you are in the emergency department in this patient is to roll the patient, both sides, make sure you find all the holes. That's the most, and that is why I think log roll in a penetrating patient, penetrating injury, should be done on C. It's part of your circulation.
Exactly, yes, I agree.
I agree, and it's a very, very important point. Okay, this patient was rolled over, and this is the only thing they found was there's only one stab, right fossa, that's the only one, and a non-bleeding, no external bleeding, and he has a non-bleeding laceration of his left arm. Nothing on the nothing behind, nothing in perineum, nothing in axilla. Now what?
OR.
What else do you want before we move him to the OR? I mean, you agree, you seem to agree that you're going to the OR. Is there anything you want before?
Blood typing?
Chest X-ray.
Just X-ray? Mm-hmm. Anything else?
No, just blood typing and go for it. He has bilateral equal air entry. I would forget the chest X-ray and get some blood typing and get the patient into the OR as soon as possible.
Where's the Diego with the ultrasound?
Why not ultrasound? Why not ultrasound before chest X-ray?
Mm-hmm.
After I roll the patient, and when I'm sure that there is only one hole in his belly, I can use ultrasound to check blood inside, and so have a clear idea about what's happening inside his belly. I can check his chest too with ultrasound. In the same time when I do primary evaluation. After that, I can decide more precisely the final destination of my patient, give a label of my patient, if my patient needs operating room instead of further investigation.
Okay. Is it going to change your plan?
Sorry?
Is it going to change your plan? Does your ultrasound changes your plan?
Probably not. Probably not. But I can spend I can waste my time if I use my probe to check these two things. If I see free fluid in abdomen or in chest.
Okay, so exactly, this is the discussion I wanted for this patient as an introduction. So ultrasound is very useful very often, but I also think it's important to see where is the limitation, where might it also delay treatment. This is a lower abdominal stab. If you don't have access to a chest X-ray, I tend to agree. You want to see that there is no blood in the chest. So if you do, whether you use ultrasound or X-ray, in this situation, in this setting, the patient got an X-ray. But I think, Jonathan, we should move to the poll now based on the discussion and let the participants vote what they would do, and we can read the options. So either you do the ABC, whether you get to the D and E or not, with the chest X-ray or a fast, or a fast of chest, IV lines, operating room for laparotomy, or you start resuscitating the patient during your primary survey and you go to CT if the patient is stable enough, or you intubate in the emergency room, you resuscitate, you do a fast, and you do, then after that go to the OR for laparotomy, or you do a massive transfusion protocol, X-ray, fast to the operating room. You go to the OR first, and then you decide based on an ultrasound whether you're going to do laparotomy or laparoscopy. So now it's up to you to vote. Jonathan, you tell us when it's over, when you want to give the.
I will do, but there are still a lot of people who are.
Can we vote too?
Think about the decision.
Can we vote?
No, you're not
Can
allowed.
we vote, Tina?
No, it looks like from Jonathan. Host
Bottom
and
line
panelists
says you
cannot.
can't.
It's a red
Okay.
line on the bottom. I'm sorry, there's no option other at the end here.
So
Yes, that's exactly my point. I would like to make a provocative suggestion, but I'll wait for the end of the poll.
Sure.
Okay, right. Well, we'll stop the poll there, and that is what the audience would do.
Okay. So that means almost 40% would do the primary survey, find out whether there is bleeding in the chest, get IV lines in, and do a laparotomy. Was that Henrique who wanted to come with the provocative?
Yeah, my point of view is this patient has an obvious abdominal injury. We don't suspect any thoracic injury, and even if we do, he's better off in the OR, where we can do a damage control laparotomy. And so this patient will not need either chest X-ray or fast, and should go directly to the operating room for a laparotomy.
I think that's a very, very important point you make. I think the point is to see immediately in the emergency department that this patient will need a laparotomy and you don't need to do anything else. In this case, I think we can just are you closing it, Jonathan, or can I do it? Yeah, okay. In this case, you are not able to, in our setting here, you're not able to not get a chest X-ray before you can do anything else. So I can't actually, Jonathan, why can I not forward the slides? You need to unmute.
You should be able to, Tina.
Sure.
Okay, we'll try. Oh, well, they will. Okay, so in our case, the chest X-ray is done over the patient within a few seconds after arrival anyway. So there's no, so anyway, that's ruled out. But I agree, I don't think there is a need to spend time during ultrasound or anything in that setting. And this patient is an obvious it's a no-brainer, basically, because it's a lower stab wound. You know you have to go to the abdomen, and from the abdomen you can see whether someone has been in, whether that knife has been all the way to the chest or not. So I agree with Henrique, you don't need anything else. So nothing should delay that patient moving, okay? So what is about these cases, it's also that these are real cases, and this was a case we had in mortality or morbidity discussions because it was not perfectly managed, because it was managed the way we tend to manage our blunt trauma patients. So it's actually to make a statement about penetrating being different. This patient, the fast was done and it was obviously positive. I mean, how would he not, how would he be that in shock with only a stab abdomen if it wasn't that he was bleeding in his abdomen? He had a bad blood gas. So it took them 30 minutes in our emergency department. Based on this, it took them 30 minutes to decide to go to our operating room, which is next door to the emergency room. And they managed to put in 6 units of red blood cells and 6 units of plasma and 1 unit of platelets while they were, before they actually was able to move that patient to the operating room. And this is because blood trauma, you resuscitate, you see the effect, you see if the patient stabilizes, you see if you can do a CT scan. Well, you don't, in a penetrating trauma patient, bad physiology means that the patient is bleeding somewhere and nothing is going to help that. So the only thing they're looking at when they resuscitate is if they can pour blood quicker in than the patient can pour blood out, which is not worth it. So this is, again, once they finally got to open that abdomen, 3-4 liters of blood, and they found the only injury was inferior epigastric artery in the abdominal wall. Okay. Is this a damage control case?
Tina, can I ask a question?
Sure.
You write down the intubation. Do you do it in the ER or in the OR?
Intubation is done in the OR while the surgeon, good point, while the surgeon was prepping. So the patient is prepped and intubated at the same time, and the surgeon is ready to cut once the patient is intubated.
Yeah, the knife and the tube should dance together, right?
Exactly. And they shouldn't be waiting. So again, it shouldn't be, so the operating room nurses should not wait to prep until it's intubated. So it should be done at the same time. But once this is done, the patient had a sick blood gas and so on. Is this definitive surgery or is it damage control?
What about the bowel lesion?
So the bowel lesions were repaired, simple repair.
Okay.
Run through bowel, find them, repair them, stab wound, simple.
Those ABGs were before the moving to the OR or at the present moment in the OR?
Where they are, and then they sort of improved immediately when they stopped the bleeding. They could turn off the tap. They got better blood gases. Everything normalized very quickly.
Okay, so that's a very good point because the patient did a very good ratio of transfusion. If the patient physiology improves enough, not all patients are for damage control. Some patients are amenable to definitive surgery. So why not? As long as you are sure you don't leave anything behind that could, a ruptured bladder or another hollow viscous injury that could compromise the outcome.
Exactly. So this
definitive if good physiology.
Yeah, I think this definitive surgery was absolutely something that he tolerated. Everything was done after they had done the repair. Patient was doing fine. The only thing was that it was a waste of blood products before he got to the OR, which is not very elegant. Should he have a CT scan after this? Anyone from panel? Everything looked fine. Perfect, sort of systematic.
What? Of what?
Yeah.
Of what? A CT scan of what?
You tell me. We tend to do CT scans of everybody, don't we?
But of what in this case? It's a stab wound of the right lower flank. You did a good exploration. You saw, I believe you should do a Cattell brush to check the retroperitoneum, check if the cecum is not perforated, the ureter is fine, the iliac vessels are fine.
You did do a Cattell brush in the patient when you have a perfectly normal retroperitoneum and an anterior stab?
If I have doubt and if there is blood, and probably with epigastric, there is some retroperitoneal blood that might have dissected retrogradely. If there is some blood in the retroperitoneum, I would explore. Yeah, otherwise, if it's perfectly fine, if it's only anterior abdominal wall, I would not. But in any case, if I'm really sure that the abdominal exploration was negative, I would not go for CT.
I agree with you. If there is doubt of anything retroperitoneal afterwards, instead of doing full exploration as well, there is obviously always an option for doing a CT scan if you doubt anything after the operation. But this patient, there was nothing. I mean, what you only found the anterior wall bleeding and some holes in the bowel. Everything else looks beautiful once you got the blood out. So the patient did not go to CT scan. Awake in ICU. After I was woken up, well, they woke him up in ICU. Got an epidural because of the long midline incision. Goes to the ward day 1 and discharged after psychiatric evaluation on day 8. So the whole point with this was the last slide of the patient, was again penetrating is different, but since we have most places in Europe, we have a sort of limited amount of penetrating injury. We tend to treat them the way we treat blunt, which is not good. It's much easier to treat penetrating. I would be cautious about bypassing the emergency department in general, because that's where we know where things are and the team knows how to work together. But it can be shortened from, instead of half an hour, it could be 5 minutes, and the team has to be prepared for that. Well, that's basically it. I think we should leave the word to Diego. Jonathan, should I just stop sharing?
Yes, if you stop sharing, Diego can then start with the presentation. Just to answer one of the questions, that presumably was not a damage control operation, and you closed the abdomen.
Yes, we closed the abdomen.
Yeah. Okay.
I would just add to say that it was actually a damage control procedure, but doing a damage control procedure was also actually the final thing you had to do. You could complete. So, patient was an easy case.
How many wounds were there in the small bowel?
I think we found 6 wounds in the bowel, and that's the other thing we have to learn about. So to actually know how to run the bowel properly, and the fact that you can miss small holes in the bowel. I mean, these cases, obviously, this patient was unstable. It is not a case for laparoscopy, but even the stable cases, even the best laparoscopists miss holes in bowels, in the mesenterial side of the bowel. So if there's penetration of the abdominal cavity, I would say you open the abdomen. You do a full exploration of the abdomen in order not to miss the holes.
Okay, thank you.
Just a technical comment. In the meanwhile, we are having the next presentation. Would you please reply to the question and answer?
Yeah, I'll mute myself and reply.
Okay. May I, Jonathan?
Please do.
Okay. It works? Do you see my screen?
Yes, yes, Diego.
Okay. So it's clear that I'm ultrasound fan, for sure. Using ultrasound since 2000, more or less. And I'm a big fan of ultrasound. So if I had to evaluate pros and cons about ultrasound, my first question, if I were an attendee, will be, why? Why have to learn how to use ultrasound? Why have to spend my time, often very few, to do that? And so my answer as a speaker will be, wouldn't it be nice to see through the body? Wouldn't it be helpful to see what's happening inside the patient in real time? Real time is important, and bedside, without any concern about radiation, without concern about the times you have to repeat this check. Okay, you ask, give you this opportunity, easily and cheap. The second consideration is about the time and target. The most important thing in trauma is time, as we see before. In an emergency setting, the patient has a few time to spend, and we clinicians have a few attempts to find the correct way. We all know perfectly what killed the patient in the golden hour, and ATLS has taught as well. A before B, B before C, and C before D, and so on. So we need a tool, quick and focused, that provide us in a very short time binary answers to focused questions. Ultrasound is perfectly fitted to this check with a lot of new application, starting from fast protocol to the point of care, so-called US application. eFast. eFast is an ultrasound application that changed literally the way to manage the patient in emergency. From 70s to nowadays, ultrasound provide always better machines with better performances, always smallest and cheapest. So, ultrasound application in trauma started a long time ago in Europe. The first report was made by Christensen in 71, but only from 90s, ultrasound was recognized as a valuable tool in trauma evaluation. In 1950, Rosicki coined the acronym FAST, and a few years later, EFAST. At the end of 19, after an extensive consensus conference, Tom Scalea blessed FAST as the first modality of imaging in trauma, with evidence of great positive predictive value for laparotomy in unstable patients. In 2003, FAST was included in a TLS algorithm, driving further diagnostic steps or therapeutic modality. Sorry. Okay, but what are the targets for EFAST? For sure, not morphology nor function of organs, but only two simple things: fluids or air in the wrong place. These might be my questions. My patient is dying for what? Because he's bleeding, or he can breathe, or maybe both. That's the question to answer with EFAST. These are well-known sites of scan in EFAST. Okay. And this is the algorithm about US enhanced management of trauma patient. Starting always from physiology, ultrasound can detect quick who need operating room or maybe further investigation. Moreover, ultrasound can be repeated more and more, or better, must be repeated in all the patient without a definitive label to discover problems in the very early stage. Some technical data. Digging deeper about EFAST, there are some questions worthy for an answer. First of all, I'm really in good hands with EFAST. Can I trust in ultrasound in trauma or not? These are what literature says us. From 90s to today, ultrasound in trauma has become strongly reliable. Ultrasound has proven to be a fundamental tool as a first-line imaging, provides data that helps in any decision-making and about the chances of needing immediate surgical treatment. For detection of pneumothorax, ultrasound is, in this review, among the others, is clear the value of ultrasound. X-ray performances in a supine patient to detect pneumothorax more or less is like guess the side of a flipping coin. So the answer is really easy. For the pleural fusion, sensibility and specificity are similar and good for X-ray and ultrasound. The difference is made by the volume detection, 60 milliliter for ultrasound and more than 200 for X-ray. What could be your choice? Ultrasound is the greatest tool for fluid detection in a very early stage, for sure. And if all these are not enough, this is the final consideration made by Liechtenstein in 2005. Point of care ultrasound will be always quicker than any chest X-ray. About free fluid in abdomen, all data shows a great specificity and a good sensitivity of ultrasound. This value of sensitivity is related to the volume and the operator skill. In the works where are enrolled skilled operators, this value raises up close to the 95%. The ability to detect a fusion inside the body cavities rise up from 90s to nowadays due to improving technology and always better and better performances of machine. Actually, the amount of fluid detectable from ultrasound is around, in average, to 100 milliliter. To reach this goal, over the technological improvement that plays a role, some tricks as a transdermal position plus rotation in one side of supine patient. These tricks are learned from experience on the field. In conclusion, it's enough glass of fluid for a prompt ultrasound detection. It's very important. But it's not always easy to compose a quick definitive picture of patient. To do that, scores helps to have a good ultrasound suspicious index for a therapeutic laparotomy. First, Wang, followed to McKinney and Stirling have elaborated scores with a strong correlation to needs for surgical procedures. These scores are easily applicable in a few seconds and immediately gives an additional warning and helps you to plan further action. But remember, the amount of hemoperitoneum or free fluid is not the unique criterion for choosing the right treatment. Don't forget the physiology of patient. About the pneumothorax, it's funny, read the whole books, very famous books, where it's wrote that ultrasound imaging is not useful, definitely, for evaluation of pulmonary parenchyma. The things changed, and Liechtenstein show a lot of signs that help us with a great sensibility and specificity about pneumothorax. It's the same in this work from Soldati in 2008, and other authors more recently. And this conclusion, ultrasound is the preferred choice to diagnose a post-traumatic pneumothorax in a supine patient. Evolution of this tool. FAST was a pioneer, immediately followed from eFast, and then it's closed? No, for sure. More and more new application was born, giving to the physician a new tools for their daily practice. We start from FAST and arrive to ABCD ultrasound enhanced evaluation. The ultrasound has become our new stethoscope and give to us a new instrument, represent a new instrument for our evaluation and guide all this process of evaluation of trauma patient. As evidence of what had been said, since 2000, many protocols have been prepared, from fluid detection to bone structure, to shock assessment, cardiac performance, central nervous system evaluation, pulmonary embolism, endotracheal tube check, and many other things. Here are listed some protocols among the other. As you can see, are a lot of protocols. As I told in 2007, Luca Neri and colleague coined a new acronym for this evaluation, for this evolution, of ultrasound. Ultrasound ABCDA. In this document, ultrasound are integrated in every steps of primary evaluation with ultrasound in very extensive way, following the ABC principle, from emergency room to the ward. We'll be interested in talking about all the aspects of evolution in every single application, but it's not time and for sure it's not place to do that. But let me show a quick slideshow of some of them. It's very interesting endotracheal tube placement check. Generally, guidelines recommend to verify properly placement of the tube by quantitative waveform and tidal capnography and portable chest X-ray. It's easily understand that all this is time consuming. Multiple studies have validated ultrasound as a quickest and useful tool to confirm ATT placement in the emergency department, bedside and real time with high sensitivity and specificity. Sternal fracture are relative common findings. Sometimes is the only small price to pay for a correct use of seat belts. Potentially, these fractures are dangerous, and usually the first modality of imaging is X-ray. Unfortunately, X-ray aren't good tests and are time-consuming. Ultrasound performance are much better for accuracy and execution time, fit for all because are radiation-free. Moreover, ultrasound check can highlight related injuries as a pericardial pleural effusion or hematoma, suggesting an immediate deepest diagnostic workout. For long bone fractures, the advantage over conventional X-ray are, as usual, lack of radiation exposure, low level of pain caused by mobilization, and better availability, particularly in isolated areas, such as developing countries. Many studies report high sensitivity and specificity for ultrasound in dangerous fractures. Sensitivity in fracture is higher in children than in adults. Another field of application of ultrasound is the rapid assessment of volume. About this topic, we can find a lot of protocols because with ultrasound is easiest way to draw a picture of volume status. Putting together cardiac performance, chamber size, heart rate, IVC diameter, and is collapsing rate, lung evaluation aorta, we can draw a very good idea about the status of my patient and maybe the reason for is a shock. IVC evaluation is one of the most important and very easy step to create and provide an immediate check of volume assessment. About solid organ injury, for evaluation bedside of solid organ injury, once again, ultrasound show great aptitude, first of all, of its sensitivity and specificity, especially after introduction of contrast and enhanced ultrasound. Ultrasound is helpful, use it to monitoring non-operative management, bedside, and without radiation. About this pioneeristic field, ultrasound to monitoring intracranial flow and intracranial pressure is a relative new field of application. Intracranial Doppler is known since 2000 and help specialists to monitoring blood supply and this variation. The ultrasound ICP check is an indirect evaluation based on size and protrusion of optic nerve. These evaluations show a good correlation with invasive ICP and becoming an alternative where invasive ICP is contraindicated. Well-known ultrasound-guided procedures, most popular as vascular access, thoracentesis, paracentesis, pericardicentesis, etc. It's not time to talk extensively about this step, but it's really important because it's an aid to do these things in safer and easier way. In conclusion, ultrasound can help and drive all decision-making process in all emergency fields, giving to physician a lot of information useful for decision, making more effective and efficient clinical choice. Ultrasound are real time and bedside and can easily learn them. My hope is that in the next future, all acute care surgeons become able to play with ultrasound, making easier all decision-making process in emergency and trauma. Thank you for your attention.
Thank you, Diego, for that very thorough overview of the role of the ultrasound in emergency and trauma surgery. Any of the panel like to comment? I will ask you a question first of all. What you've said there essentially is that you can use an ultrasound more or less from head to toe, which is an enormous amount of a skill set that you'd need to train people to be able to do. Your fast scanning and your e-fast scanning are fairly easy to teach. But by the time you're looking at intracranial pressure, by the time you're looking at long bone fractures, how much training would an emergency surgeon need in order to be able to be competent at doing all of those things with ultrasound?
It's a good question, Jonathan. Not all of these applications are fundamental for acute care surgeon. It's very easy when you become skilled in ultrasound, improve your skills with this application. for my personal experience, I can say that these relative simple improved skills. Also with the application, newest application as an optic nerve evaluation, ICP, or transcranial Doppler is not so difficult. But the fundamental things is that in trauma, our patient dying because he's bleeding or can't breathe. So the first step is to have anyone in his hands e-fast, because it's fast is not time consuming, can be applied in the same time during the primary evaluation without spend more time. In the same time, when the nurse acquiring vascular access, you can complete a fast scan. The value of this scan is that provide you a lot of information about the patient. In the first, in the early stage, only about air and fluid. But when your skill improve or rise up, you have a lot of information, because all your scans are a picture of what's happening inside the body of your patient. When you perform, for example, epigastric scan, you can see, first of all, pericardic fluid or effusion. But with the more experienced eye, you can see how the heart work. You can see the chamber size. You can see if the left or right side work better. You can see inferior vena cava and so on. So you can create a very detailed picture of your patient with a single and very fast examination.
Can I make a comment?
Oh.
Well, I agree, and you are. I agree that it's very valuable in trauma and in many other situations, and it has become more and more relevant. And it's good for those who actually have the experience and can use it. I think one thing that maybe hasn't been said is that there are some limitations. There are lots of possibilities, but there are also limitations. And the point is, there's very few things you can exclude with ultrasound. You can see with ultrasound, but you cannot necessarily exclude. And I think that limitation, being enthusiastic, also takes time. I think it's also about what institution are you in. I mean, we get our X-rays much quicker than any radiologist can do in the past. Even if the radiologist is standing there when the patient comes, it takes shorter time to get the X-rays. So I think it has to be, there has to be some. It depends on the situation you're in. And the other thing I want to say is that all of that is good, but we're back to also what changes the management of the patient. Because you say it's quick. If you're skilled, yes, it's quick, but does it make a difference? And sometimes it does, sometimes it doesn't. And I think we need to cut down to some things are fun to do, but not always. Relevance is important. We have to have in our back of our mind, does this change what I'm going to do with this patient? And then we need that skill set. Absolutely, agree.
You said a very important thing, Tina. Ultrasound can be time consuming if the probe is not in your hand. I like to say an example. When you need to check a chest, you call a pneumologist or do it yourself. That's the secret. When I need to check something with ultrasound, I do myself. I do by myself.
But Diego, even if the patient is dying in front of me, even if you do it with the best of hands, if it's not necessary, if it doesn't change management, it is wasting time. It is time consuming. Even if it's as quick as anyone can do it, if it's not necessary, so actually that part has to be, it's fantastic when you need it. But you have also many situations for trauma, it's actually not needed. And it doesn't make a difference. Like the patient I showed you, doesn't make a difference. And then it will take time.
But no, it don't take time. Because in the same time, your Naess acquire a vascular access, I perform a complete my scan. It's contemporary, it's not time consuming.
Back to the point, I think people have to think, what does make a difference in patient management? I think that is important to have in the back of your mind when you're good with ultrasound.
Okay, what
Can I make a comment? Sorry, Diego.
Yeah, please
Yeah.
kill me.
No. So, some of the applications you've shown, really, I have to agree with Tina. Finding out sternal fractures or finding long bone fractures or measuring ICP have no immediate management implications in management decisions of the patient. However, having an ultrasound that quickly says that there is a right or a left pneumothorax, there is pericardial fluid, and there is intra-abdominal fluid in a blunt trauma patient, in a patient where you might be bleeding, but you don't know where is bleeding. I think the ultrasound is an invaluable tool to use, and I totally agree with you, Diego. It should be an extension of the C doctor in a team approach. The C doctor should be holding the ultrasound probe and should be with the expertise to perform this assessment of the patient in order to get priorities, not get diagnosis, in order to get priorities. Another tool that you've shown, and you just went over it, what I think is a very good tool, is we're increasingly using Riboa. Some of us, at least I'm not, but some of us are increasingly using Riboa in resuscitation. It's still an ongoing discussion, yes, which no definitive answers yet. But the ultrasound-guided puncture of the femoral artery in a shocked patient is another potentially valuable application of ultrasound in these cases. And indeed, the placement of central lines in patients where you can't find a good IV access. So I believe ultrasound, I agree with you, Diego, is here to stay. We should perhaps focus on the priorities. We're doing primary survey, and the ultrasound should assist in the primary survey, and it's a great help. So it's here to stay. That's just my comment.
Tina says very important things. With ultrasound, there is a great danger. We can't teach to interpret fantasy. Ultrasound give us information only if I am sure about what I see. About what I can't see, or I'm not sure to have seen, ultrasound is not affordable, is not reliable, sorry. So we have to be clear, ultrasound is a tool, as a Riboa. We have to use when it's time to use it, for sure, I agree with you.
Well, the difference is that ultrasound is not killing anyone, Riboa might, but that's another discussion.
I don't think we want to go into Riboa as a discussion this evening, or we'll never.
No, we're not going there. Okay.
Can I move the discussion on to the next case then?
Yeah.
So, Paul, if you can show us your case, that would be...
I'm going to pull up Paul's slides, and I'm leaving the screen to him. There we go.
So this is a pediatric case, as you can read, and it's a simple one, actually. This was an 11-year-old, previously healthy boy. He had a non-motorized scooter accident, and he came into a local hospital with an obvious abdominal trauma. His A was okay. His B saturation was 100%. His respiratory rate was 20. His C status was maybe okay. Blood pressure 130/78. His pulse rate was 90. GCS of 15, and E was okay. Secondary survey showed that he had a tender left abdomen, and he had gross hematuria. So, based on this, what's next? Should this patient be brought directly to the nearest trauma center? TC stands for trauma center. Or should he be brought to a CT scan? Immediate operation. That's up to you.
Okay, and as you can see, majority of people would do a CT scan, but a very close second is to immediately transfer into a trauma center. Interesting.
At least nobody wants to operate.
No one wants to operate, and that's probably because we have learned that kids should actually undergo a non-operative management in the majority of cases. But would some of the panelists argue that this patient should go to the trauma center directly without any further diagnostics or treatment?
My experience, I have no experience with pediatric patients. So because we have a pediatric hospital, so probably I transfer the patient to the trauma center in order to deal better with this patient. Exactly.
And of course, it depends on where in the world you are and actually the geography. Because in our region, it's actually a short distance, but could be up to 2 to 3 hours by car transfer time. So again, depends on. But the patient was more or less hemodynamically normal. He was a little bit tachycardic, but otherwise. People, they think that based on what they saw, he could tolerate the transfer to the trauma center, and he could also undergo a CT scan. Okay, next slide then.
Right. There you go.
He underwent CT. And I'll show you first the coronal view, 3 of them. You can here see the first one from posterior and in the forward direction. You see the upper part of the left kidney, a large renal hematoma. There you can see the lower part of the kidney appearing. And on the picture to the right, you can see that the kidney is more or less in 2 pieces. And you get the same impression when you see it in the sagittal view from lateral to medial, 2 parts of the kidneys, and then the most inferior one actually disappears, and you see the upper part displaced. Same when you see it in the axial view. Big perinephric hematoma, and more or less what you get an impression is actually a kidney split in 2. Both of these parts are actually perfused.
Oh, may I ask a question?
Yeah.
Is there any arterial blush in CTE? And the second question, is there any sign of a urine leak in the later phase enhancement of the CTE?
This CD was actually done in a local hospital, was just done in the phase you saw, was not a late phase. So we have no actually knowledge about whether it was a urinary leakage or not, but there was no ongoing extravasation.
And what arterial extravasation because it was a very good arterial phase?
Yeah. No.
Was there arterial extravasation?
No arterial extravasation.
No arterial, okay.
Based on this, would you observe this patient in the ICU? Would you operate on him, or would you transfer him now to the trauma center?
Paul, can I ask, was there retroperitoneal confinement?
Yeah. Yeah. Very little, or at least neglectable fluid within the abdomen.
And at this point, most people would transfer him to a pediatric trauma center.
Okay, yeah. He's still in the same shape, so he can tolerate a transfer to the trauma center, which was actually what they did. And the patient came in to our center 3 hours after the injury. Primary survey was okay. He had still a tender abdomen. He had also pain in his left shoulder, and he had hematuria. The CT was, before he came, was re-evaluated by our radiologists, and they pointed out that he had what they thought was a transection of, more or less a transection of the pancreatic tail, as you can see here in an axial and a coronal view. So, based on these findings, now what? His hemoglobin in the trauma center was 11.3. His creatinine was 61. His amylase was 20, which is in the lower normal range. His bilirubin was 5. And he has quite a nice arterial blood gas. Will you observe or will you operate on this guy?
The patient is peritonitic.
This is actually not this question. Okay, this is actually for the panelists to discuss whether you would observe or operate based on the findings that you actually saw that the radiologist said that he had a pancreatic injury. Do you believe the pictures?
Can I opt for an MRCP?
Yeah, what we actually did was we examined the patient and we looked at the picture, and they don't look as an ordinary injury. That's probably more or less what we can see is something congenital. It's a normal variant, and we did not actually pay much attention to that. So we neglected the so-called injury to the pancreas. His amylase was normal at that point, but that doesn't matter because you might see rather severe injury of the pancreatic duct, but still you have normal amylase at least in the first 12 hours. But within the first 24 hours, you probably have an increased amylase if you have a significant pancreatic injury.
Well, may I ask a question? I didn't quite understand. You took this pancreatic imaging change as a congenital lesion. However, if we go back, I believe there was a bit of a different enhancement in the images between the body and the tail of the pancreas. And this, we have a kid with a very typical mechanism of injury of a pancreatic injury.
Yeah,
which is a bike accident, a scooter accident.
Yeah.
And how did you make this decision for a congenital change with the mechanism of injury and with this slight difference in enhanced between the tail and the body of the pancreas?
I'm probably actually going backwards. So on the axial view, you might get an impression that this might be an injury, but what you can see in the coronal view is actually this is very unlikely as an injury. This is,
okay, but at the left side image, at least for me, I'm not sure the rest of you guys, but I see a bit of a difference in enhancement in the tail of the pancreas and the body of the pancreas.
These two
but it could be just an impression, of course.
So you have to actually go and see the pictures yourself together with your radiologist, and you have to actually see more or less every picture and in different views. Then we ended up concluding that this is probably not injury related, and we ignore it. So we based us on a NOM strategy. He was slightly improving from day 2 to 4, but on day 4, his urine was suddenly macroscopically normal. So what should we do now? Is that a good sign or a bad sign that the urine on day 4 suddenly is macroscopically normal?
It could be bad because it could mean thrombosis of the of the left renal artery. Was there any pain at this moment? Any sudden pain?
No, he was slightly improving, and but he had a very clear, it was very obvious that he had a macroscopic hematuria, and then suddenly it was normalized, and that actually worried us, because then we thought that maybe he has an obstruction, and this kidney is not actually giving urine to the bladder anymore. So
why not ultrasound?
I'm agree.
To see hydronephrosis, and also with Doppler sign, Doppler flow, see the vascularization of this kidney.
Yeah, as you saw on the primary CT scan, there was good circulation of both the upper and the lower part, and we saw that he had a macroscopic hematuria, and at this stage we didn't want to do an ultrasound because we had actually no belief in that he would have a hydronephrosis. But so we went actually directly to a CT scan. And this is an extracellular phase, as you can see, a late phase, and you can see that both in the axial and in the coronal view, you have uroplania. So, based on this, what should we do? We'll observe him, do percutaneous drainage, put in a JJ stent, or operate.
Mm-hmm.
There were quite a split amongst the audience.
Yeah. So,
Paul, sorry, if I'm going too much on my own, just let me know. But I'd like to make a comment.
Yeah.
Was urology involved at this stage? Because we're not in a damage control setting. This is an almost elective setting.
Yes.
We're talking about an 11-year-old kid.
Yeah.
With the full resources.
Yeah.
I believe urology should at this stage be highly engaged in the treatment of this patient. This is not a damage control setting anymore. It doesn't need an emergency. It's not unstable. So I believe we should have them involved.
Yeah, we have a very good collaboration with our urologists, and me as a pediatric surgeon, I'm competent in urology as well, but we have actually a very good collaboration with our urologists, and they were involved at this stage. So there are actually some discussion. We don't use percutaneous drainage at all. So if we want to actually drain the system, we put in JJ stents, and someone just wanted to observe, and a few people wanted to operate at this stage. We had a discussion, and we felt that this might end up with an operation. So he got a double J stent and put in by one of our urologists, and he was followed for almost another 2 days, but he didn't improve.
What did it improve?
He didn't improve. He was actually a little bit exhausted. He was tired. He had a little bit of nausea, but he had some intraoral intake, but he wasn't improving. He was actually a little bit deteriorated, maybe. So at that stage, we decided to have another discussion about what to do, and as you can see, observe, put in an extra percutaneous drainage. Still, he had some hematuria at this stage, but it wasn't that obvious as it was before the first 4 days. And of course, new CT scan or operate.
and the majority view is that this child should have an operation.
Yeah.
Giving up on the kidney.
Oh, how was the pancreas in this second CT scan?
In the CT scan, looked normal, and he had normal amylase throughout the course. So he had a laparotomy. This is the kidney. You can see some infarction, and actually it was taken out in 2 pieces, as you can see on the picture on the right. With just some small adhesions along the Gerota's fascia. So this was almost a complete divided kidney. His postoperative course then was uneventful, and he was discharged home 4 days later.
Paul, can I ask you what was the consideration to perform surgery on this kid now?
Based on that he didn't clinically improve, and we suspected when we actually went through all the CT scans that this was actually such a big injury that what you always see when you have blunt trauma to children, grade 4 and 5, they look like they are exploded, but still they are connected in a way. But in this case, when you actually went through the CT scans, you got an impression that it was more or less completely divided. And the chances actually to get a good outcome with a well-functioning kidney was deemed more or less like 0 at that stage.
He was becoming more and more tired, more and more gray, more and more, you know, his eyeballs sunk in and so on. He looked more sick instead of getting better.
So the clinical deterioration is key to determining whether or not to operate, and not the injury itself, right? If he was improving, more patients could be allowed.
Lack of improvement, actually. I think we should all agree on that. The kids are challenging, and if you're in a smaller hospital, do like they did in this case. When they could, they transferred the patient to the trauma center. Still, it was a challenging case. Again, you have to compare the clinical findings with CT scans and vice versa. So what you see on the CT scan should actually fit into the physiology of the patient. And if the patient seems sicker than the findings on CT, then you should always listen to the physiology. Non-operative management is a cornerstone in treatment of children with abdominal injury, but from time to time, you need to take them to OR. And you should also be able to reconsider your strategy when it fails. And I think in children, it's extremely important that you decide, when you do an intervention, decide more or less in advance. If this patient doesn't improve within, let's say, 2 days, then you should take 1 step behind, go over your thinking again, and if it's indicated, reschedule, do something else. Just don't be passive and let the days go by, because then you end up with a totally exhausted patient and with a bad outcome.
Well, I have a question for you.
Yes.
It's not a comment, it's only a question. Do you think that in this case, a contrast enhancement ultrasound could have a space in the monitoring of non-operative management of these kids?
Actually, no, because I think that what we did, or what they did in the first place, they should have actually, when they saw that it was a big injury to the kidney, they should have had a late excretory phase in the same CT, in the first CT scan. And then we would have known that he had had an extra or uroplania. Then we can actually have put in a double J stent very early, and without actually any improvement on day 3 to 4, then we should actually have reconsidered, made a second CT scan, I think. And based on that, we should actually been much more aggressive and actually going through all the CT scans to see that there was actually a big displacement of the two parts of the kidney, indicating that this kidney was actually completely, more or less completely divided, and the chances for a good non-operative outcome was more or less like zero. So we were some days too late before we actually were able to decide to do an nephrectomy in this case. That's the learning point.
Thank you.
Can I make a comment on that, Paul? Because we looked at our cases for renal injuries, and half of the patients with urinary leakage did fine without double J stents. So
yeah,
maybe not always necessary to perform those. It depends on the type of injury and whether or not there's retroperitoneal confinement or not, I think.
Of course, and many of those kids with renal with urinary leakage as well, they're small and they're within the capsule. So that's no indication for the double J stent by definition. Then you follow the clinical course. If they deteriorate, then you do a repeat scan and then you put in a J stent. Yes, completely agree.
Okay, thank you, Paul, for a very interesting case. Can we move on, Shahin, to your presentation?
Yes, sir. I'm just gonna jump into it. So, as we have already discussed, hemorrhage is one of the most preventable cause of deaths in trauma. This is the case. We get the ambulance report, male, 23 years old, multiple stab wounds to abdomen, one stab wound to lateral right chest, ETA 10 minutes. We didn't get any vitals on this patient. This is the first report in the ED. He's hypotensive, a systolic around 70-80. He is in distress. The respiratory rate is 35, saturation 97% on oxygen. So the first question, where do you want this patient and what protocol? Do you want to do your ABCD in the ED with EFAST chest X-ray and then take him to the OR? Because obviously this patient is gonna end up in the OR sooner or later. Or you wanna go to the ED and go for a CABDC CD with the femoral sheet for a REBOA and then OR? Or straight away to the OR with the ABCD and OR with or without using a REBOA. So this is for the audience, then we can discuss.
The overwhelming majority want to stay in ED, do your ABCDE, and then either do an EFAST or a chest X-ray, and then take the patient to OR. I think we've seen that response before somewhere.
Okay. Falco, what would you do?
Yeah, I think we would do the same. So patients arrives in the ER, we do quick EBCD, and then go to the OR.
I'm not sure what quick means, basically, because when the patient gets to the ED, just transferring him from the stretcher to another stretcher and take him off the clothes, and then nurse is gonna do whatever they do. And Diego wants to do his ultrasounds. What is the fast time in the ED?
For us, the fast time in the ED is, well, at least all patients should leave the ED within 20 minutes, and these patients within 12.
Okay. So I was the attending on call for this guy, and I opted for the OR, and this was a case from Iran, so we don't have a REBOA, so he didn't get a femoral sheet. So the question is, if the patient has a stab wound and is hypotensive, is there a role to stop by the ED? That's the main question, because I don't see how it's going to change my management, and I can do my ABCD in the OR where I have the OR nurses, which are the best. They give me what I want and quickly. Enrique, do you have any comment?
Yeah, Shane, thank you. This is a highly interesting case, very challenging one. Thank you for bringing this case. You're right. Patients with penetrating trauma belong in the OR. However, sometimes not all OR teams are as proficient in the team approach to non-technical management of the severely injured trauma patients. This should not happen, of course, but you get a more consistent level of team approach at the emergency department, then sometimes you get into OR. This obviously needs to change. It's up to us to improve this with the courses, with user simulation, obviously, and we should also train the OR teams for these case scenarios. I agree with you. If you're comfortable with your operating room team, go ahead and take this patient directly to the operating room. Otherwise, I would, in my personal experience, as I'm more comfortable in the ED, I would just put some intravenous lines, get the blood typing, and then transfer, exclude that the patient does not need a chest drain in the emergency department, and then proceed directly to the OR for the intubation and the laparotomy at the same time. I mean, draping the patient during intubation and go for laparotomy, obviously taking care. I don't see the chest the wounds, taking care to include all the chest as in the STC from the chin to the mid-thigh, draped in order to do laparotomy, thoracotomy, whatever the patient needs.
Thank you, Henrique. Tina, you want to jump in?
No, I just want to say to reinforce the same thing. I think that most trauma teams, at least in Europe, I think we need to have a system, and the system is made for us not to make the simple, stupid mistakes. And the system takes the patient to the ED, but you can take down the time we spend, and that's hence my reinforcement of the difference between penetrating and blunt. This patient screams to you that he wants to go to the OR, and it's up to the trauma team leader and the team to be trained, drilled enough to take that time down to the minimum, and that means maybe maximum 5, 6, 7 minutes, and then the patient should be moving. And I think that if we can do that everywhere in Europe, and if we could drill people to do that, I think we do better with penetrating.
Thank you, Tina.
My other question to you, just before anything, would you really dare to put a Reboa? I mean, good for the patient that he did it in Iran with no Reboas present, because I think if you look at the low abdominal stab there, are you sure that's not in an artery where you actually can make more wrong with putting in something inside the vessels?
That's up for debate.
I would be worried.
I'm not for Reboa in penetrating trauma. So that's a contraindication for me. So if I have any patient with a penetrating trauma to chest or abdomen, I would defer from putting in the Reboa.
Makes sense.
I agree with Shane. Reboa in penetrating trauma is a bit of a no-brainer. I mean, the patient is bleeding, he needs an operation to control the hemorrhage. For me, we had a great webinar on Estes on Reboa. For me, still Reboa, the main value is in blunt pelvic injury, where you need to do something while the patient is sanguinating from the pelvis. For me, that's the main indication. In this case, not go for Reboa, hypotensive resuscitation and laparotomy.
I agree. So, what would you give him? Would you start a clear solution bolus, go with the erythrocytes, massive transfusion protocol straight away, or wait with the massive transfusion protocol and have it ready to go if the patient deteriorates? So this is for the audience. Okay.
Most people, as you can see, would go for massive transfusion protocol with tranexamic acid.
Alan, what's your approach?
Tranexamic acid, for sure. How long do the trauma take? How long take the patient to go to the hospital? 15 minutes? I don't remember.
Well, no, we got the ETA for 10 minutes. So let's say 20 minutes from the trauma.
So, and the pressure now is 80.
Yeah, it's 75, 80, depending on who you ask.
So it's penetrating trauma, so I think I bring the patient to the OR and start the massive transfusion protocol when the patient is in the OR.
Okay.
Hypotension, the permissive hypotension.
Yeah. So this patient is already in the OR. I didn't take my boss's advice, Dr. Tina Gaarder, and I took this patient straight to the OR.
Can I just say something anecdotal? Yeah, because I remember some great words by Ken Beaufort when he said this patient has the deficit of one factor, which is the silk factor, which is a deficit of a clotting factor, which is known as the silk factor. You know, a silk or proline factor.
Yeah, sure.
The correction. So again, we are doing one-to-one ratios, but remember hypotensive resuscitation and urgent control of the bleeding.
Yes. So this patient went to the OR. We didn't start a massive transfusion protocol. We had the blood with us, but we waited to give it to him until if he would crash.
Shahin, can I just make a comment?
Yes.
And that is because I think some people in the audience might have misunderstood a little bit from the previous case. It was not, even if we gave one-to-one and took the patient to the OR, I think you make the point correctly. The point is what we should have done. So it was not properly managed in my mind, the previous one. What we should have done is to keep back when the patient is awake. We don't give anything, but we should have it ready. And I think that goes for penetrating more than anything else. Don't put in blood because it's not just going to bleed more. And the only thing you're competing with is whether you're going to pour in quicker than the patient tries to pour out. You're just changing patient blood for someone else's bank blood or something.
I think that's an important point, Tina, that you have your major transfusion protocol activated so you have it ready if you need it, but you don't start giving it just because you can.
No. You have to stop your anesthetist from doing that.
Yeah, that's the hard part. Here, on this picture, these are the stab wounds that the patient had. So now we are in the OR, and what comes next? Do we intubate the patient, then prep and dress, and do the laparotomy? We intubate, go for the chest tube, and then a laparotomy, or chest tube, prep and drape, intubate, laparotomy. What sequence of management would you do? So this is for the audience once again. And I see there are a lot of questions coming in. I'm going to try to answer them after this presentation. So chest tube, prep and drape, intubate, laparotomy is the majority of the answers. Henrique, how would you do?
Well, it's either the second or the third options are correct. If we are comfortable with having a chest drain ready in the OR, it can be done at the same time. While the anesthetist, we have to have a good teamwork and coordinate this very well. Have good pre-op briefing with the anesthesiologist and the nurses, and while the patient is being intubated, go with the draping, with the chest tube, and we're proceeding with laparotomy, almost at the same time. I would highly suspect there is a right hemothorax or pneumothorax, and if the patient doesn't have, we will of course the pneumothorax, which will be treated with the chest drain. So just go for the chest drain during intubation. You will minimize the risk of hypertension pneumothorax, and then you can proceed with laparotomy as well. And furthermore, during the laparotomy, you can check bleeding from the chest as the laparotomy goes from the output of the chest drain.
Exactly. And that's exactly how we manage this patient. We put in the chest tube, and then we went on with the intubation and laparotomy. That was the plan. So putting in the chest tube, we didn't get any blood output. We did prep, we didn't drape, because the patient, after he got intubated, suddenly was severely hypotensive. And then the blood was pouring in. So this question is for the panel. What would you do now? Do you go for the thoracotomy because he's hypotensive and he's not getting any better? Would you go for the laparotomy, or this is where you ask for the balloon, the boa? Henrique.
A challenging case. If the patient deteriorates during induction, I should at this stage be ready to do a laparotomy, a swift laparotomy, and then go for the hiatus and clamp the aorta. Use the hand, use whatever you have, put a fist against the spine. At this systolic pressure, you're not gonna feel much pulse, but it might improve the conditions a bit to clamp the aorta at the supraciliac. If, however, you find a very large retroperitoneal hematoma and you can't find the aorta easily at this stage, then I would suggest a swift left ventrolateral thoracotomy and clamping the descending aorta. But my choice first, laparotomy, not Ribua, obviously. If you don't find the femoral pulse that the patient was 80 systolic, we're probably not going to find it at 55 systolic.
Falco, do you agree?
Yeah, I fully agree. This, we would have had the patient prepped during intubation. So if he crashes after the intubation, we'll be ready to perform laparotomy, find the hiatus, and manually compress and go on from there.
Okay. I'm glad that we did as the experts on the panel are saying. We did the laparotomy, we scooped out the blood, and we pressed the aorta just below the diaphragm, as Henrique said. So we saw several small bowel perforations and a large hematoma in low zone 1 on the right side. This is where we did the cattle brush maneuver, and for those who haven't done it, basically in these cases, the blood has already done the dissection for us. And then we found the proximal common iliac injury. At this time, the patient is obviously in severe shock, so his pH is 6.9, lactate 12, and he's cold. We decided to go for a damage control surgery here. And first of all, we shunted the iliac artery. I hope you can see the plastic tube here.
Shahin, what kind of tube are you using?
That's a good question. The one that they give us. I don't know which tube I use there. So we basically take anything. We can take an NG tube, anything that fits the vessel. And this is in Iran. So basically whatever they give us, we use it.
It has to fit the vessel, so you have to decide the size, right?
Because for the iliac artery, it's nice to have a Yavichunt or something. They use
No, we don't have the nice stuff over there at the moment. So this is a question for a panel again. What's your next move? Now we are 50 minutes into operation. We have shunted the iliac vessel, and we have primarily closed the small bowel injuries. So would you go on with the resuscitation and fix the common iliac, close the abdomen, and then take the patient to ICU? Or you're gonna go down the road with the damage control surgery, keep on resuscitating, and then go with an open abdomen to ICU? Falco?
Yeah, I would choose for the second one. So keep the shunt in, suture the small bowel perforations, and keep the abdomen open, revive the patient in the ICU, and then come back to fight another day, make your anastomosis.
Shahin, can we ask you how the blood gases were now, and how much blood products have you given so far?
They were bad. We had given in the end of the operation, we're going to come back to it. We had given 7 erythrocytes and a couple of plasma. So the gas was bad. He was hypothermic. So
your previous slide was 34 degrees, right?
34 degrees, yeah. So we went on with damage control here. We took the patient to the ICU with the open abdomen and the shunt in place. And obviously it was to correct the acidosis, the hypothermia, and coagulation.
Okay, may I say something, Shane?
Yes.
This case, congratulations, it's a great case. I'm just loving it. This case really illustrates well the concept of the DSTC course. We all know the DSTC course, the decision making about the DSTC course, which is, you know, we don't need the special shunts, we don't need the special vascular toolkits and gadgets. We need the simple procedures that will stop bleeding, stop contamination, stop ischemia, which is the internal contamination, which will also cause later multi-organ failure, and this will keep the patient alive. So just this comment, a great case.
Thank you, Henrique.
Use whatever they give you. Exactly, that's the correct answer. Use whatever they give you.
Yeah. Thank you very much. So here's another question that is coming back. Tina had this as well. Is CT indicated? If so, before the ICU or a second look? And why is this important? Because there was a study done, I think it was from Pittsburgh and published in Journal of Trauma, where they saw that even with the damage control laparotomy, there was missed injuries. So they advocate for the CT scan. So in this patient, how many of you would go for a CT scan before the ICU or before the second look?
ICU look. Yeah, go ahead, Falco.
I think we should go to, we would go to the ICU first, resuscitate, and then make a CT scan before the second look. We had 2 cases with large aortic dissection after stab wound. So you have to find those injuries as well.
I think it also.
Yeah, I totally agree with Falco. We should. This patient is begging to be resuscitated. He's hypothermic, coagulopathic. He should go to ICU because the CT is a very dangerous place for these patients. It's cold, it's away, they're not monitored as well. There is time for CT just before the second look.
Or you can say that you can't wait until almost the second look in order to find missed injuries. So you can also make a case of
You know, we can hear you.
Diego or someone?
I didn't hear you, Tina, but
I think the point was. I think the point made was that the CT scan is indicated. I think in that case, with 4 stab wounds, it's probably indicated at some stage. And and you're perfectly able to resuscitate during a CT scan depending on your institution. I think, and the point is, I think that inform the patient while you're in the CT scan. You can have ongoing transfusions if the patient is doing better towards the end of the operation. But I think it's a case-dependent decision to make.
But will it change your management? A positive finding in the CT scan?
Depends on what you hit in the chest and so on. I think it's a good idea to have that CT scan. And it doesn't make, but if you don't need it after that operation,
this is a very scary case presentation, because at this time we have to keep in mind 2 points. The first one is the physiology of this patient that doesn't allow it to perform definitive surgery, but also don't allow it to stay outside the ICU for many times. And the second point is what the Tina said just before. We didn't have any good exhaustive information about the chest. So we have to keep in mind these 2 points: the physiology of the patient and the information about the chest. In my personal opinion, I think that I bring this patient in CT scan during the resuscitation, and this before bringing him in the ICU.
Okay, can I ask, what are we expecting to find in the chest? A blunt aortic injury? This was a stab wound.
you can have a stab aortic injury that's not bleeding.
Well, with a blunt trauma, I would accept this answer, but with a penetrating stab wound, right-sided, right flank, right thoracoabdominal injury, I would not suspect significant intrathoracic injury, otherwise than the hemopericardium that can be excluded either in the OR by opening the diaphragm, or with a point-of-care ultrasound at the bedside at the end of the OR.
We had aortic thrombosed aortic stab wound in the chest. from a patient like
Okay,
that.
but you have just completed abdominal exploration and you found pulse in the distal iliac and in the aorta and you in the left iliac?
In the chest. There was an aortic injury. We've seen that in patients that had thrombosed, a small hole, but it's just temporary that is thrombosed, and you can suddenly have a bleeding. So there's no,
Okay.
again, it has to be paranoid. If you're in control of the patient after towards the end of that operation, you know the patient is going to CT scan at some stage. It depends on your patient whether you want to take him for a short time to ICU to get more control of physiology and take him back, but I wouldn't wait just as a routine to almost the next operation, because then you probably don't need a CT scan anyway if he's still fine at that time.
I'm glad we got the discussion going. So I'm going to go to the next slide here. So we took this patient back to the OR within 24 hours when his pH was normalized and his blood pressure was okay and his coagulation was normalized. Unfortunately, we don't have TEG in Iran, but I highly recommend it if you have it, to look at the coagulation and clotting cascade using the TEG. And this is the final result. So we did put in a graft, proximal iliac, and you see the ureter and the vena cava behind there.
Very nice.
So that was the whole case. I tried to touch somewhat on if you should stay in the ED for these patients. Like I said, I don't totally agree with my boss, Professor Gaarder. I feel more comfortable to having these patients in the OR where I can get my scalpel as soon as possible. And the next question is how to resuscitate them. I would keep them hypotensive as long as possible, or permissive hypotensive. And then the damage control side. So if there are any questions, I would love to answer them. Otherwise, Dr. Tilsed.
Yeah, thank you, Shahin. That's a very interesting, very difficult case, which has been very thought and discussion provoking. You've got quite a few questions there to answer in the Q&A system, so you can relax now and do that while Tina presents the final case.
Yeah, so I answered the kidney ones, so you can go on with the answering the next ones. So I'll go back to just a very short, because now we have been focusing on, all these young trauma patients. Okay, so I promised you to have the extremes of age, and I think at least in most of the world we have increasing number of old trauma patients, and blunt is much more challenging than penetrating. And penetrating is always entertaining, and it's fun, and we should train to be good at it, because patients who come alive with penetrating, they should walk out alive from hospitals. So then we have, whoops, here we go. This is just to provoke some final discussion on maybe on ethics more than anything else. Okay, 75-year-old female. The story goes that we get the alarm from the pre-hospital dispatch center. He has fallen from a high second floor, about 10 meters, okay, onto concrete. There is obvious chest and extremity injury. She was found with her head on her knees, more or less, and not breathing spontaneously. Her GCS was 3. She was intubated on scene. She got an IV line and bilateral thoracostomies by our pre-hospital guys. How do you prepare for this? You just put her aside, let her die. She's old, massive injury, death probably, head injury maybe. Anyone has any? How do you prepare for her?
The same as always, just get ready for a major trauma.
Or, in my mind, it's either she's more important to be aggressive with because she's old, or she doesn't have a chance. Any 17-year-old takes this much better, or 40-year-old takes this much better than she would. So it's a matter of hyper urgency if we want to have good outcomes in old people with trauma. Okay. Should we order?
You made a good point there, Tina. The meaning of futility in trauma care. That's a very, very good point, and I believe that this will probably be one of the points that you mentioned. But I believe the good thing about trauma is you don't care about futility at the early stage. There's always time to care about that later. So with aggressive management, older patients, which European countries are increasing the proportion, can get a good outcome. And so a GCS of 3, I mean, there are several hints that this patient will have a very bad outcome. GCS of 3, namely the no spontaneous ventilation. But I mean, give it a shot, why not? And be aggressive. I would go for it.
Okay. Anyone against, or everybody agrees with Henrique in the panel?
I agree.
I agree with Henrique, for sure.
75 is not so old.
Yeah, she's younger than my mother.
All in.
Okay. Okay, so now how do you prepare? So in my mind is, if you want to go for it, she's more urgent than any 17-year-old, any 40-year-old, because she has that one shot and you need to actually do it right the first time if you want to have a good outcome. Okay, fine. So you want to order blood before she arrives? Okay, you prepare your team. You tell her that this is, we need to be on the ball here. We need to get IV lines early. We need to start resuscitating early, assess her, etc., and be efficient. Do you want to put a binder on the bed, on the stretcher?
What? Binder?
Binder, stolen from 10 meters.
Pelvic binder.
I hope that she have binder from the scene.
Oh, it might have, but not always. Okay, it's a good idea.
If not, it's a good idea. I have on stretcher.
You want to prepare chest tubes? Do you think she's going to need chest tubes? She has bilateral thoracostomies. That means small thoracotomies.
Yeah.
Yeah.
Just follow your ABCs, prepare your team, assemble your team, get someone to get the A, because intubated may not mean that it's properly intubated, could be in the esophagus.
Exactly.
Sometimes it can happen from the pre-hospital. Get someone in to put a chest drains. Even if the patient doesn't need them, she's gonna need them because she has the bilateral thoracostomies. And the busy guy will be C, because a 75-year-old with no tachycardia doesn't mean that's not much of a blood loss. There could be severe bleeding. Get blood in the room, O negative blood, and prepare a massive transfusion protocol, because a 75-year-old female might have taking antiplatelet therapy or NOACs. And so you have to be very aggressive with the resuscitation of this patient.
So is this a patient, she let's say she lives in Oslo and the trauma center is in Oslo. Do you want to check her files before she arrives?
If there is time, obviously, yes.
Well, there's always someone who can do that while others are receiving the patient. Maybe that's a good idea. Yeah, I agree. You have to think the worst about this patient anyway. Okay, fine. So the patient arrives. She's intubated. She has a neck collar. So what do you want to do for Henrique? You mentioned you want to see if the tube is correctly positioned. What kind of, do you want to do ultrasound?
No, I checked for fogging at the tube, check the saturations, and listen to the lungs.
Yeah, and we have
if Diego is there and the ultrasound is ready, and if I have doubts, I will ask him to check the tube. But otherwise, with these clinical cues and with the ETCO2, it would be enough for me to ensure the patent airway.
In Oslo, an X-ray takes 1/10 of the time that Diego takes to check that tube. Okay, so the X-ray of the chest is going to be there in 10 seconds, and that is less than Diego takes to find out where the tube is.
In this case, ultrasound is redundant. So, I don't think that ultrasound in this case about the chest can provide any information that change your management.
Diego, we're talking just about the tube first. Okay, so intubated neck collar, trachea midline. She has air entry equal. She has massive subcutaneous emphysema. She has an oxygen saturation of the 92% and completely unstable chest wall, not even tested. It's moving all over the place. She has cool clammy periphery. Here she has a blood pressure of 86/49 and a pulse rate of 110. Okay, she's intubated, but she has equal and reactive pupils. She has obviously mashed lower extremities. Okay, so loose fractures, femur, ankles, feet, and suspicion of pelvis. Okay, so now we're working on getting IV lines in her. Obviously not in from the lower extremities. It has to be upper extremities and central. Okay, they're struggling a little bit to get good IV lines, and starting massive transfusion, level 1 warmer, 1:1:1, tranexamic acid, you name it, right? We're all starting during that. Do you want to have x-rays?
Are the chest tubes placed already?
Not yet. They're on the, so they're on their way. They're starting to put in chest tubes both sides. But while in the meantime, as I said, you can't actually get in a chest tube in Oslo before the chest X-ray is taken. Okay. So
may I ask why, Tina? Because I disagree with this policy. This patient really requires a chest drain before the chest tube, the chest drain before the chest X-ray.
Yeah, you cannot disagree with something that's actually so efficient that you cannot avoid it. Obviously, obviously we would put in chest tubes immediately, but the chest X-ray is there before you can actually, even if they're packed out the chest tubes, there is no way you can get the chest tube before the X-ray is hanging over the patient. The radiographer is there before the patient arrives, and the chest and the plate is under the bed of the patient before the patient is there. So it takes less than 10 seconds to get that X-ray. So you actually are not able to put in a chest. Even you wouldn't be able to put in a chest before you get that X-ray.
But
you're very lucky.
In line of thinking, it doesn't change her.
We're so lucky. No, so now we are so lucky that you actually have an X-ray without the chest tube. Can you tell me something about that X-ray?
Well, yeah. If we follow the ABCs of we see that the tube is a bit too in to the right stem, almost a right stem intubation. I would pull the tube a bit 1 or 2 centimeters up.
The carina is actually lower than you think.
Oh.
Yeah, it could dislodge it, but could go down more and compromise. I see so much emphysema. I'm not sure there is pneumothorax. I would go for the chest drains at this stage. There is no mediastinal enlargement, so I don't suspect a blunt aortic injury, but this patient will probably have a full CT scan. And he has a lot of emphysema, so again, I would go for the bilateral chest drains at this stage.
So this patient has no peripheral pulses whatsoever. She has only central pulses at the moment. Are you taking her? Not yet, right?
Are we, sorry?
So she doesn't have peripheral pulses at all. Are you taking her to a CT scan yet, or do we just wait for effect of resuscitation before we move her towards
No, wait for effect of resuscitation. This patient is unwell at the moment to go to CT.
So the other thing is, how well can you see in this patient with an ultrasound? Does it make a difference? Because you want the chest tubes anyway, don't you? Yeah, you have thoracostomies, you need the chest tubes, and that kind of subcutaneous emphysema does make it a little bit more difficult and time consuming. This is her pelvic X-ray. You see, she has, you can't see the behind very much, but you see both FCF fractures, both sides. And she has acetabulum on that side. She had rami and probably something behind. We can't see very well. Okay, her blood gas taken in her femoral artery comes back with a pH of 6.9, a lactate of 13.1, and oxygenation not too bad. She's on the ventilator. This is the one with her 2 chest tubes.
May I ask, was a fast exam performed to see if there is free fluid?
No, I don't think so. We'll come to, I'll tell you afterwards why. So this patient is now, we suddenly get back, someone mentioned the fact that she might be ill from before and that we were supposed to check her files.
She had a pH of 6.9, right?
Yeah.
So this is the time we reevaluate futility of care.
Okay, so now she does respond to transfusions. At the same time, we get back the information from her files. Okay, they've been checking the files. She has a severe grade 4 COPD. She's on steroids. She has a very low tidal volume. She walks few meters with a walker before getting completely dyspneic. She has severe atherosclerosis on aspirin, marginal lower leg circulation. She's admitted to hospital several times last year and now in a nursing home and jumped. And there's no, this was from our pulmonologist, there's no view for any kind of improvement of her lung functions. She now has, go back to that. If you look at her chest x-ray now, look at her chest wall.
It's shattered.
It's shattered both sides.
A lot of fractures.
Every single side. She also has completely fractured, pulverized the ankles, feet, and both femurs. Can I ask you?
Even in a young, healthy patient, a pH of 6.9 would cause a lot of effort to get them up and running again, even without all the fractures on the lower legs.
She does now respond. She has better pulses. She does now the pulses centrally. No pulses are still. So this is my question now to anyone. This is not actually for Paul. What would you do? You're standing there as a consultant. What do you think is her chance of getting out from hospital alive?
Few.
0.
Very low, very low.
Very low, like 0%?
What?
1%?
No, 1%.
So I'm back to Henrique's comment. Henrique's comment about the fact that we don't, futility is something you never actually consider this early. Well, in this woman, I did, and I ended her treatment in the emergency department based on these findings. And I think, and that was, but after having consulted the whole team.
Tina?
Yes?
But, you say that after resuscitation, patient hemodynamics improve. And
no, I said he has some kind of response to resuscitation. Yes, of course, we could have poured in.
Also glycoma scale or not? Glycoma scale or 3?
GCS of 3.
Okay.
No, I'm just saying, she would, I could have continued, we could have poured in 3 more packs. She would go to the ICU and she would still die over the next days, week, months. She would get multiple organ failure, absolutely without any kind of suspicion. So you end up with a situation where this woman is not going to come out alive at all. And the kindest thing to her was actually to stop. And this is something we very rarely do early.
I fully agree.
But this was, and we asked the senior anesthetist at the end of the table, and I said, look, listen to the story, her anamnesis from before. And with this combination of injuries, even before we've done a CT scan, I'm happy to go on to resuscitate and get a CT scan and let us see all the fractures before, and her head, before we make the decision. But the decision is going to be the same anyway. And everybody agreed that, no, let's end. We talked to the morgue after she had gone through autopsy. She had 2 to 3 fractures per rib, all ribs, both sides, completely shattered chest and completely shattered lower extremities, no head injury and no spine injury. But still, I think that was a correct decision, but it's very seldom, and I agree with Henrique, very, very seldom we give them a chance and we think later. And for some patients, we pull in, we end treatment within the next day or 2 or 3, depending on how it goes. But I think for old patients, it's all in, and many of them come back to a good level of function, like before they came in, but it requires really that we are on the ball with them. And some patients actually don't, and it actually happens sometimes that we should end early. That's the kindest thing we do to them. Any comments from panel on that before we stop?
Yeah, usually we define that the futile treatment patients with severe irreversible head injury. We had no idea in this case the head trauma, but this patient already had a very limited respiratory reserve. She had very severe respiratory COPD, and it's highly unlikely, I would say impossible, that this patient would ever become, even if all goes well, even if she doesn't get infection, out of the ventilator. We all studied the 3-modal approach, 3-modal peaks of mortality in trauma, the immediate, the early, and the late stage. But elderly patients also have this first peak of mortality, which is in the first year after the trauma, which is when they go to the nursing homes and really without quality of life. So this was a brave decision, Tina. Especially this should be a collective decision. This should be discussed as possible. It's a very difficult decision to make, and this should belong not just to the team leader. It should belong to the team as a whole. If possible, involve someone from internal medicine, someone from outside the team to also give in their input from the intensive care unit, because this is a very difficult decision. But ultimately, I think it was the most humane thing to do. You know, do not proceed with futile care.
Exactly.
I think that in this case is a good example of teamwork decision. Could be not up to only a team leader or a surgeon, but should be a result of teamwork. Otherwise, we can risk to give a futile care, and this is not a good choice. But it's difficult for one person to decide about other person. It's only a result for a teamwork with the anesthesiologists, their medicine, and so on, to have a numbers about e-survival.
It's also, I think it's not only that, it's also about knowing that the rest of the team is comfortable with you doing or understand the decision, because it's a tough, it's a very abrupt decision to do that during early care. And I think you need to know that everyone has understood why, so that it's not becoming something very dramatic for them.
Indeed, you have to ask if there are any objections. Everybody can feel in with the decision that is made.
Yeah. Okay, Jonathan.
Okay, thank you, Tina. I think that's a very good, very appropriate place to stop with a very good, very thought-provoking last case. I think also this is the point at which you have enough information to make that decision about what's best for the patient. And let me just, put this up. So at this point, I hope you've enjoyed this webinar and will join us again. Estes webinars are going on tour with a webinar special next Monday, Mission Impossible Trauma, in association with the Norwegian Surgical Society as part of their autumn meeting. And in 2 weeks, we'll be going to Spain and Latin America with the Spanish Association of Surgeons for a webinar on thoracic stab wounds. As always, you'll be welcome to join us and should receive registration links for both of these events after this webinar. Tina, do you want to tell us about the Norwegian meeting next week?
Yep, I was just wait.
Okay, I can share that screen. Hang on.
Can you go back to my thing? There you go. There you go. So this is
it.
Yeah, that's for next month. I don't know why. Can everybody? I hear my time. Jonathan, maybe.
Okay, Tina, we've lost your sound at this point, but the meeting next Monday is in 2 parts, from 6 to 7 and from 7 to 8. And as you can see there, we'll be covering technical and decision-making challenges in major trauma, and trends and truth in trauma resuscitation, with an excellent international panel to discuss both of those sessions. We have had an excellent international panel this evening, and I'd like to take the opportunity to thank Diego Mariani, Paal, Naess, Shahin, Mohseni, Alan Biloslavo, Falco Hietbrink, and Henrique Alexandrino, as well as my co-moderator, Tina Gaarder, for an excellent set of cases, presentations and discussions. We also have a fabulous backstage crew without whom this would not have been possible. I'd like to take the opportunity to thank my good friends, Hayato Kurihara and Mauro Zago. Thank you all for joining us. Hope we'll see you next time, and goodbye.
Thank you.
Bye.